Hi, everyone. I'm Jason Starr. I'm a GI medical oncologist over at Mayo Clinic, and happy to be here with you today to discuss disparities in GI oncology.
Hi, everyone. My name is Richard Kim. I'm one of the GI medical oncologists currently at Moffitt Cancer Center in Tampa, Florida.
So, yeah, we're happy to be here. It's an interesting topic that Dr. Kim and I were discussing before the recording. How, it's something we see in clinic every day, and kind of conceptualizing it and discussing it is a different uh, angle for us. So this is going to be fun discussion. One of the topics that I had chosen to highlight when we were approached with this topic was the disparities that exist in gastric cancer. Anecdotally, in my clinic, which admittedly, I'm in Jacksonville, Florida, kind of by the beach, and we take care of mostly white patients, I would say, as we're speaking about disparities or underrepresented minorities. However, I do have kind of a moderate proportion of patients who are Black, Hispanic, who I take care of with stomach cancer. And it got me thinking, you know, these patients tend to be younger. They tend to have more poorly differentiated or signet cell histology. They tend to have more peritoneal spread. Uh, and sure enough, when you go diving into the data, for example, the AACR report that came out last year, well, the biggest difference in terms of incidence and mortality of any cancer in the Hispanic population was between gastric cancer in terms of the difference, absolute difference. And second cancer that had the highest difference in incidence and difference in mortality between white patients and Black patients. So it's all right there, and I do recommend that folks look at that AACR report, which kind of gives the state of affairs, if you will. So it kind of gave some background and some context to this discussion. And sure enough, folks have done NCDB database analyses, SEER database analyses, and have found that indeed there seems to be a discrepancy in population of patients in terms of relative incidence for stomach cancer in the Hispanic and the Black population. Now, what are some potential, you think, okay, well, why does that exist? Well, some biological potential basis would be, so there seemed to be a higher incidence of H. pylori in those population of patients. And if you look at some of the basic science, it looks like H. pylori hypermethylates the CDH1 gene, which is E-cadherin. So that kind of maybe gives us an insight in why you see more of the diffuse histology, the more, the signet ring histology. So that explains it. But the caveat to that is when you look at the TCGA analysis, which that paper is beautiful, that was published in Nature a couple years back. It subdivides all of the esophageal, lower esophageal, and gastric subtypes of cancers. And Dr. Kim's going to talk a little bit about colon cancer, which we got the CMS classification years ago. Well, gastric cancer did the same thing, and this was based on a big tumor, cancer genome atlas. Well, guess what? No Hispanic patients included in the analysis, and very few Black patients. So what we know from a biological standpoint is limited because we just haven't studied it. And then so it's frustrating when you're in clinic and the disease is different, but you don't really know how to approach it differently because you're not armed with the knowledge to be able to understand it. Because anecdotally, and I couldn't find any data on this, actually I did find one paper, the signet cell or the poorly differentiated histology is mostly HER2 negative, PD-L1 negative, and proficient mismatch repair. So all the biomarkers that we have available to us are not useful because they're negative in terms of using targeted therapy. The other thing, and I think Dr. Kim's going to touch on this from the colorectal standpoint, is early onset gastric cancer. So we're seeing a lot of attention, rightfully so, for early onset colorectal cancer, defined in both situations as being diagnosed with age less than 50. And well, sure enough, when they look at the NCDB analysis, they saw a higher proportion of patients, proportionally Black and Hispanic. So we're seeing early onset gastric cancer more in these patient populations too. And, I think Dr. Kim and I will maybe discuss kind of as a whole some of the social inequities that exist, right? Structural racism, access to care. A lot of these patients come from environments or communities that are under-resourced, right? A lot of them of these patients don't have a lot of formal education. And that again is structural racism, which is a much bigger topic than we're going to tackle today. Um, and so that was something that came to mind. And then one thing that we were going to discuss too is clinical trials, right?
Right.
We talked about underrepresentation in the TCGA. How do we get more patients represented on clinical trials, which has been a big push from the NCI. And, for institutions to even become NCI designated, they have to represent their catchment area, right?
Right.
Whatever area they serve, essentially. And so the NCI recognizes that historically, across the board, in medicine, in oncology, underrepresented minorities are underrepresented in clinical trials. So the applicability of the therapies we have is somewhat limited because if we are appreciating there's biological differences between racial groups, then that's not represented in clinical trials.
Right. Thanks, Jason. So so a little bit of, once again, from at least from my perspective, I'm currently at Moffitt Cancer Center, which is tertiary cancer center, and just like yourself, most of the patients that I do treat are mostly Caucasian as well, with a certain portion of African American and Blacks and Hispanics as well. So at least in one of the racial disparity that's clearly been published and documented is in colorectal cancer. If you look at all the literature, there's no doubt that there's a higher incidence and higher mortality of amongst Blacks in patient with colon cancer. So the question is, why is that the case, right? And there are a lot of literatures and research done on it to figure out the reason why the Blacks do worse. And I think there are many factors. It's not just one or two factors. I think there are definitely some environmental factors, that contribute to it, such as maybe diet, obesity, smoking, that has to do with. Also, the colon cancer is one of the diseases that's potentially preventable, right? That by cancer screening colonoscopy, you could actually able to prevent the cancer. However, some of the communities, there's a mistrust of the U.S. health system that could potentially prevent them from getting the care they need. Okay. As you mentioned, access, right? Prevention, you need access. If you live far away, or if you're not aware of some of the current recommendation that you should get colonoscopy at 45, if you don't know that, then you're not going to get screened. Okay. So I think some of the environmental factor could be a factor in the racial disparity. And there are maybe some of the not modifiable factors that we're not aware of. Okay, we're trying to learn more about it. For example, if there's family history, is there a genomic difference between African American Blacks and and whites and Caucasians? And I think more and more research are being done to figure this out. But clearly, the Blacks tends to have more of a tumor that's in the proximal side, more of a right-sided tumor, And if you look at their, do a profiling of their tumors, they tend to maybe have more of a KRAS mutant kind of tumors, okay? And maybe some of the data show they have more of MSI high tumors, which could be more aggressive behavior at the, when the patient develops stage 4 disease. So, those are some of the factors that could potentially play a role in why and there could be a racial disparity. I don't think there's a one answer that fits all. But as you mentioned, there are definitely more work to be done in this area. And one of the areas that at least in my practice that I've seen is that you know the trials that, as you mentioned, I'm saying, I think that, as part of oncologists, I think clinical trials do play a big role, in a setting. And I think there is definitely bias in trials. If you look at all the results in the clinical trials, bulk of them are Caucasian, right?
Yeah,
80%,
for
70%
sure.
Caucasian, except maybe in gastric cancer, where there, as you know, there are a lot of trials done in Asia. Maybe
Yep,
that's one exception where you will see, a lot, 30, 40% of Asian population.
absolutely.
In colon cancer, what's African American, blacks, Hispanic, these are 10%, maybe less than that. And we know that we don't know at this point, but maybe some of the drugs may the efficacy may be different amongst ethnic group based on their background and the biology of tumor. We don't know that because there's not enough samples of them. Okay. So I think, moving forward, I think those are the areas that we have to focus on. And some of the trials, I think rightfully so, are now requiring to have
Yep.
this many proportion, to have blacks, Hispanics, or Asians, whatever, in the trial, so that, at the end, when you analyze it, I'm saying, maybe this drug may not work for general population, Caucasian, but it may actually work for blacks for whatever reason. I think those are what we have to learn for the future studies.
Yeah, no, those are some really well received points, and I agree with all of them. This was a study that was published in AACR here that I'm sharing, that was done with Kaiser Permanente. And so we talk about, like, okay, what can be done? And as Dr. Kim mentioned, a big part of colorectal cancer, in terms of improving outcomes, is improving screening. And so from 2006 to 2008, the Kaiser Permanente group sent home, at home colorectal cancer tests. I'd imagine they were hemocol tests. And sure enough, colorectal cancer screening uptake increased, right? And so they were showing, I don't know if this initiative continued, but from 2000 to 2019, 80% of Black individuals were up to date with their screening guidelines in the Kaiser Permanente system. And then sure enough, they decreased the difference in colorectal cancer mortality between Black and white patients. So these are the type of initiatives. But I think, Dr. Kim, your point about some distrust from the medical system, right? With good reason. We always think about the Tuskegee experiment where, where Black people were treated inferiorly and like test subjects, which is hard to overcome, in history. And then the underrepresented minorities continue to be marginalized. So developing that trust, I think, involves, education, is a big component. So doing a lot of outreach. I know Mayo and Moffitt, do a lot of outreach to just do some general education. Hey, what's a colonoscopy? What does it entail? What do we look for? And gastric cancer, the incidence in the Asian countries, the Eastern countries, has gone down because they developed standardized screening because the incidence was so high. So the question is, if we're seeing a high incidence in underrepresented minorities, should we be doing screening, right? And that takes time for the United States Preventative Task Force to get on board. But with that being said, when we started seeing early onset colorectal cancer, the age for colonoscopy changed from 50 to 45. So if we see enough of these trends and that enough of the data is published, and we're kind of like, well, here it is, we know prevention is always the best treatment.
Right. So I think, yeah, I mean, so as you mentioned, the racial disparity could be definitely, we could narrow the racial disparity by screening process as a clear example of if you're able to screen them, the patients, and knowledge is out there. And, there has to be champion, right? Someone who go out in community, sort of have a connect with the community outside, to have, so that we have a relationship with them, so they trust the system, so that they could come in and get screened, get their normal medical care. I think that's a must. And once again, I think the trust issue also comes in a trial, right? When you get a comment too, when we ask somebody, are you interested in trial? One of the comments I get is, am I a guinea pig?
Yep.
You know what I'm saying? That's a comment that you and I probably get a lot, right? And that comes from mistrust, right, of the system. And like, what are you doing to me? You're giving a drug that's never been tested or something like that. So I think that's the barrier they have to overcome. But however, I will say that in my experience, that independent of ethnic group, whether you're Black, Hispanics, that if you're able to explain the purpose of the trial,
Agreed.
you're going to, hey, why am I doing this? There may be implicit bias that maybe Blacks don't participate in a study, or Hispanics don't do that because
Hmm.
of the language barrier. But I think that is false, because
I
if you're
agree.
able to talk to them, spend some time while you're doing this, I could assure you that majority of those patients will consent to the study, and they don't mind contributing to the science. It's that the first step, right, that you have to take and have to with those patients. I think that's the important step. Jason, I don't know what your experience is trying to enroll patients of ethnic group in the
Yeah.
trial, but want to get your thoughts on this.
Yeah, so I would again agree with you 100%. I think the key thing is taking the time and connecting with the patient, looking at them in the eye, and them knowing whatever you're doing is in their best interest, that you're acting in their best interest. Explaining how a trial works. Hey, this is how a phase 1 is. This is how a phase 2 is. A lot of trials, fortunately, don't have placebo as much anymore, because that in any racial ethnic group creates a little bit of distrust, like, you're going to give me a sugar pill. But I think just explaining, like, what are we trying to do with the trial, how is it designed, in simplistic words, and taking the time, but making the assumption that a patient's not interested because of, historically, you know underrepresented minorities, Blacks, Hispanics, Asians, even in the US, are not interested, or because there's a healthcare literacy gap. Well, we got to close the gap. Or there's a language barrier for
Right.
Hispanics. Well, the consent's got to be in Spanish,
Right.
and you got to get a translator in the room,
Right.
right? So it's just a matter of getting over the mental hurdle, us, before we're able to present it to the patient in a way where it's like, hey, we're just here to help you, plain and simple.
Right. No, I think yes, you mentioned it. So obviously, the moving forward, question is, as an oncologist, just like yourself and myself, what can we do, right,
Yeah,
to go out there to sort of help, sort of narrow those racial disparity, right? And there's limitation, right? We can't do everything,
sure
but as
thing.
a physician, I mean, your thoughts on what sort of solution that's out there? What can we do as a physician to sort of narrow the racial disparity, and at least try to help those groups of need, basically?
Yeah, I love that question.
Mm,
I think, again, it's a lot of checking our own implicit biases at the door.
sure.
I do this implicit bias test that was developed at Harvard with the fellows, to kind of see that we all have implicit biases, right? And those are deep ingrained from when we're really young, and from our parents, right? Things that just happen that were subconscious. So I think the important thing is, when you approach a patient, approach from a place of compassion and from non-judgmental kind of standpoint. Um, so I think that's really important, to not make assumptions that somebody may or may not be interested in a clinical trial, and to make sure that when we do offer a trial, it really is the best thing for that patient.
Mhm.
Because there's situations where it just may not be right, just based on, they're just not quite comfortable, or you know they just need time. But I would always say, it's okay to revisit it, and it's okay to, when I give a patient a consent, I always say, sorry, we can't do the consent today. I have to ask you and allow you and give you the space to go home with your family and review this and come back with questions. Because to me, a trial in any relationship, honestly, when I walk in the room, that's like a sacred bond. I take it very seriously, and I know you do too. So if I present a clinical trial, I want to allow to give them time and space, because, to the points we were making, I don't want a patient to feel rushed. And that's important from a trust standpoint. If they feel like I'm selling something, that is it's a no-go, right? Like
Mhm.
ice cold AC,
Right, right.
this new car, used car salesman. So I like to give them that space. I think, to your point, from a bigger picture, right?
Mhm.
From the NCI level. The NCI, the NIH recognizes this is a quote problem. It is a
Yes.
problem.
Yes. Yes.
And so they say, well, how do we improve it? And I'll be honest, the first step was recognizing it was a problem, right? But I do think that the NCI was smart to get more serious about, hey, if you want to be an NCI designated center, you need to represent the patients that are in your area. You can't
Mhm.
just pick and choose.
Right.
And so they've really made a concerted effort to say, hey, if you want to be part of the NCI, you want to represent your community, you need to take care of those constituents in your community.
Right. I think I once again agree with your points there. I think a couple extra point that I probably want to make is, as was brought up at the beginning, education component, very important. We have to reach out. Okay. I think that's it's a must, so that they're aware of it, in terms of screening wise, the treatment of the disease, how you sort of disease awareness, whether it's a colon
Mm-hmm.
cancer or whether it's gastric cancer, disease awareness is very important. So they're aware of it. However, as definitely the patient that I've seen in my clinic, there are some social economic barriers that actually
Mm,
prevents patients from coming in. You know, Mayo Moffitt is a tertiary center. Patient drive 3-4 hours to get there, but unfortunately, not many patients could do that.
that's a
They
good
could, they
point.
could, they cannot. Sometimes they don't even have a car. You know what I'm
That's a
saying?
good
So they
point.
need a support. Sometimes they get a ride from their family members or friends, but that becomes a problem. So I think, developing sort of some kind of to overcome this, social economic barrier is also very important to make it easier for the patients to enroll on a study would be very ideal. And this comes up where, a lot of big places, phase one places are in the big places, big cities, right?
Yep.
But if you live in the suburb, if you live in the rural area, live far away from the main campus, then maybe it's good to develop a center close to where the population is, where the, for example, where if there's a majority of blacks living in certain area communities, develop a program there, invest money in that area. You know what I'm
Yep.
saying? Instead of
Yep.
making them drive 2 hours to go to a big cancer center, develop a sort of a clinical trial unit in the area where, let's say, they're predominantly blacks or Hispanics, for example, where they'll be more convenient for them to go there, drive 5 minutes, 10 minutes, and then compared to driving 2 or 3 hours. So I think those are some of the socioeconomic barrier is something that we also have to overcome as well. And that's something that actually I've learned from my clinic, that there are patients who are willing to do it, but they just can't because of
Yeah.
their environment factors that sometimes they cannot control.
Yeah. That's the rough realities. Like, I have patients who are on the verge of getting evicted, or and involving the social worker is critical. I mean, definitely advocate, but it's such um a real point. Like, we talk about tangible things,
Right,
like, because we talk about pie in the sky stuff, like, oh, let's just
right,
do this and this, but that's such a tangible point that sometimes, like, even getting to the clinic is not feasible,
right,
you
right.
know?
Yeah, so I think, so obviously there are some factors that we could control, obviously. Question is that what's causing the racial disparity? I don't know, you know what I'm saying? Is it the
Hmm.
socioeconomic? Is it just the environmental factor, you know what I'm saying? Is that what's causing the racial disparity or lack of education? Or like you said, I think the big question is there an underlying biologic reason? You know what I'm saying?
Right.
Is there underlying genetic background in Hispanics or blacks that makes them do worse for whatever reason? And
Yep.
if that's the case, we have to understand why do they do worse, then understand, try to help those the point out. So I think, we have a long way to go. There's
Yeah,
no doubt. I mean, I think this is just a tip of the iceberg. And I
it
think,
really is.
as you mentioned, NCI now has made aware that this is the priority, which I completely agree. You know what I'm saying? Because,
It's the right thing to do.
the trial right now is not representative,
Not at
of
all.
our current population. And sometimes we could be surprised that in certain ethnic groups, for example, I think one example is with immunotherapy. As you know, a
Yeah.
lot of trials done in Asia, for whatever reasons, they do better.
Yep.
I don't think there's a good reason for it. It's unclear at this time why they do better.
Right.
Maybe maybe the microenvironment, I don't know, but that's something we have to learn more. You know what I'm saying? Is there a
Yeah.
certain drug that may work better in blacks for whatever reason, and is there a certain drug that will make Hispanic work better? So I think that's something that we have to figure out in the future.
Yeah. And I will say that from my experience in talking to other investigators, the NCI, a lot of these federal grants are very, very willing to support that type of research. Like the
Right.
funding is ripe for for studying healthcare disparities. Um, there was an investigator that I worked with at University of Florida, Dr. Trevino. He's now, I think, in West Virginia, but he was studying healthcare disparities in pancreatic cancer in Black patients.
Hmm.
We didn't touch on this, but tend to be more aggressive, tend to
Yes.
be younger males,
Hmm.
and some of that is BRCA, BRCA2 related, and some of it is not. Um, and so, yeah, I think that we need the new era of researchers and investigators to really hone in on, figuring these things out. Like
Right.
this is the next kind of iteration of research. Once you get the foundation, you're like, okay, now how can we kind of apply this to a bigger patient population?
Yeah, I think so. We have a couple of minutes left, but like
Yeah,
I said, I think there's one point that, as you mentioned, is that in Asia, as you know, due to the environment, they have a high propensity of developing gastric cancer, as you mentioned. Now in
yeah,
Japan and Korea, they screen everybody with EGD. So what they do is that they find this disease early on. You know what
yep,
I'm saying? We don't do
yeah,
that in the US, right? Obviously, but in
no,
Asia, they do that. So all the gastric cancer, they have better outcome because they find it early. So
yep,
maybe here in US as well, there may be certain disease like pancreas cancer that that African blacks tend to be more aggressive. Maybe in some certain cases they have to get screened, with a
yeah,
CAT scan or endoscopy, whatever, in other diseases. So I think that's a learning curve. Okay, that I think moving forward we have to learn, that based on the rate, based on the race, there could be subtle differences in terms of how
yeah.
we should approach them, whether it's screening or whether it's prevention or whether it's how to treat those patients.
Yeah, and I think the leadership, right? Like even at the NCCN level, right? So if we know that a certain patient population, like Hispanic women and gallbladder cancer, in certain areas, like I think Southwest Texas
Mhm.
and Southern California, carving out, like, why are we not doing ultrasounds to screen for that cancer, right?
Right,
Or so I haven't seen a policy to date
right,
that has focused on, taking epidemiologic data, some of that we
yes,
discussed, and then applied it to screening guidelines.
yes, I agree. High
So
risk,
I'm
yes, yeah,
waiting. It'd be really nice to finally to see that, even if it is, ultrasound, right upper quadrant
sure,
ultrasounds in Hispanic women in these areas.
right.
I think that would be a first step.
Yeah, I agree. So I think in conclusion, I think I would say that, obviously, I think racial disparity is real. It does exist. I think there's no denial of that. I think
Absolutely.
we could do a better job of trying to narrow the gap. You know what I'm saying? I think we talked about some of the potential solutions. Hopefully moving forward, we will make some progress on this area. And hopefully, in 2030, 2040, that racial disparity could be narrowed. Any last comment, Jason?
No, I mean, I think we owe it to our patients.
Mhm.
I always say, like, we owe it to them, no matter their creed, race, religion, to, try to make their lives a little bit better. So yeah,
Great.
I enjoyed the conversation and I loved your insights, and yeah, this was fun.
Thanks to you, Jason. Appreciate it. Thank you.
Thanks.